For those of you who don't know me, I am Bill Duncan at the University of Florida College of Dentistry. This is our work. I do with Dan McNeil also, happens to be my department chair on developing an ontology of dental care related fear and anxiety. I have to mention Alan Steele is a co-investigator here at UB. Finn Wilson, who's a student here at UB, also works on this. And we have collaborators at the University of Utah. All right, so what is, I just call it DFA, that's the typical acronym. What is it? It's distressing emotional and cognitive responses to dental treatment related stimuli. And that can mean, thinking about an upcoming dental appointment, being in a waiting room, undergoing an actual procedure, a lot of fear, of specific kinds of dental instruments. They can look kind of scary, drills and needles and things like that. And, and often this just manifests as feelings of, different distressing kinds of emotions and apprehension, things of that nature. Why are we interested in this? Because this affects oral health and it can affect it in significant ways. Of course, people with high levels of DFA start avoiding the dentist. As you get older in life, you get more caries and cavities and gum disease and tooth loss. And this, especially in your later years, can really have a negative impact on your quality of life. It also impacts dental clinics. So, dental clinics are, I guess, healthcare organizations, and it's important the way they schedule you. And when people just don't come, then it, impacts their work flow and throughput and things of that nature. So Elena will talk a little bit about this, I think, in the next talk, but there is temporal dimensions to DFA. Fear is thought to be more in the moment, fight or flight kind of responses. Anxiety is more cognitive in nature, involves worry. I'm worrying about an upcoming appointment. And it exists on a continuum. A lot of us have what they would call a normal level of fear. I know I'm getting my tooth extracted tomorrow. I'm a little worried about it. That doesn't sound very fun. To those who can't even go to get their tooth cleaned. And of course, I guess a rare few who are completely fearless about going to the dentist. All right. Part of what motivated this project were issues, say, with the DSM, and the associated, I guess, ICD codes, and where there's these, kind of 5 different high-level types of fear and anxiety. And we can see this reflected in the ICD code structure. But DFA doesn't fit nicely into any of these categories. Lots of people will think of it as some kind of BII subtype. And in some cases, there are fears related around like being injected or having some procedure done in your mouth. But lots of times it's just being in the waiting room. There's claustrophobic kind of aspects, like you're in the dental chair and you got someone or 2 people hovering over you and putting their fingers in your mouth. There's smells that can trigger fear also. And there's also issues with just in the literature of what people call fear or anxiety. So this is just an example of one study where they say they're studying fear. You find another research article. They say they're studying anxiety. And then, of course, you actually read the articles and they're both studying the same thing. And so from at least amongst the psychologists, like in our group, this is an issue, right? Because we want to be very precise about what phenomenon we're trying to measure. There are issues with, the dental medical record like systems. This is just an example of this system called Axiom, which is widely used amongst universities. And you look in there and most of the notes are about tooth-related procedures or surgical procedures within the mouth, but not much about DFA. And this can be important because if you know someone has a high level of fear or anxiety, then there are certain steps that you can take to help alleviate that. Now, for our ontology approach, This is being developed as part of the OHD. A lot of people have mentioned this subset strategy a bit, but we add a term, we tag it as being part of this subset, and that's nice because then we can relate it to other, I guess, non-DFA terms like a tooth drilling procedure. In the OHD, we also import terms from OBI and from the gene ontology and a number of others, so we also can reference those. It does a nice job of keeping one, I guess, kind of centralized spot to be able to develop it. And then, I just have a release process where we go through and we create this subset and push it out to BioPortal. And this just notes that, right, right now we have 79 classes that are a part of this subset, but once we do our release process, we end up with like 133. All right. A lot of our focus right now has been on looking at these common assessment instruments in the field. Here's just an example of one called the IDAF. And what we want to do is we want to group these and not only put, the assessment question in the ontology, but the underlying terms that they're about, right? The kinds of phenomena that they reference. So here's, one from an instrument called the Dental Fear Survey, another one from the Modified Dental Anxiety Scale, the MDAS, and they both, of course, reference something about your tooth being cleaned. Right? Oh, we went all these talks without anybody mentioning FAIR. Here's the obligatory slide. Anyway. And what is also nice about this project is that we're also getting like live patient data. And that's interesting. We have about 21,000, we have data on about 21,000 patients right now, and we have more on the way. And because we have actual patient data, it's important for us to think about how we want to take this data, mostly right now, always in this kind of typical tabular format. And we want to be able to leverage the ontology to do analysis. And we've adopted this approach using LinkML, which stands for Link Data Modeling Language, where we map terms to ontology terms. There's some tooling to do a simple RDF translation, and then we can do, Sparkle queries and analyze data sets and all that kind of stuff. One of the things we like about LinkML is that after you author your schema, you then can use that tooling to output, say, your data in JSON, which is a common format used by researchers. You can, of course, produce other tabular-like data. And then, of course, for us, we're focused on the RDF world. And I guess we'll share these slides later, but you can follow this link to see an example of what we've done with this Core 2 study. I've also kind of built on this LinkML approach. I use this some people call it a hack, but I take the classes and I pun them as object properties. And the reason why I do that is because when data scientists look to query the data, they look at the column headers and they think of them as relations. And so, right, they want to say, give me, all the age data, all the data for DFO1, et cetera, right? So that's a nice straightforward query. The problem is that if it's just object properties, then you can't leverage the axioms. And so that's why I do this punning stuff. And now I can run a query like this. This is just an example. I can say, give me all data that is about some tooth cleaning procedure. And so I'm not tied to a particular question. Now I can leverage the semantics. All right. We've presented at a number of conferences to this point, and right now we're starting to shift towards actually producing a journal manuscript on our work. We still have a lot to do. I mentioned some of the axioms we want to relate to these assessment instruments. There's more work to be done there. We have to settle on our representation we want for fear and anxiety. As I've come to discover, there are lots of theories of emotions. Our lead psychologist is not very happy with the emotion ontology because it leans too heavily on appraisal theory. So he wants to do something different, and we're working through that. And he also doesn't really want to overly commit to his favorite theory also, because he recognizes there just are a number of competing theories of emotion like in this field. And then our final goal, after we do some more analysis, like on the data we have, to, I guess, assess which other variables might be important. So for example, our researcher at Utah is starting to see that people who have undergone domestic violence or sexual abuse, they tend to have higher levels of DFA. And that's interesting. So it might mean in our ontology, we need to account for these. And this goes beyond what you typically see in these assessment like questionnaires. And our end goal is to create our own assessment instrument, and then we're going to gather data using it on live patients in one of our remote sites. So I think that's pretty cool. All right, acknowledge NIDCR for their gracious funding. And here's the contributors.